continue. Yeah. Doesn't listen to me. Hello, good afternoon, everybody. Welcome to the Journal Club. The topic of our presentation today is ROSE trial. Okay, so this ROSE trial is basically use of neuromuscular blockade in early time after the onset of ARDS. And the question that they wanted to answer by conducting this trial was, in patients who have moderate to severe ARDS, does a strategy of this early usage of neuromuscular blockade with the use of heavy sedation, as opposed to the usual care in which we use lighter sedation targets, does it help in lowering 90 days mortality? So for some of you, let me just revise what ARDS is. ARDS is acute respiratory distress syndrome. It means that the onset of symptoms should be for 1 week or less, which is why the word acute is used. According to Berlin's criteria, the patients, if you do a chest X-ray or if you do CT, you should find your lungs filled with opacities bilaterally. And you should calculate, when you do AEBG, and if you calculate PF ratio of the patients, PF means PaO2, which is there on ABG, and FiO2, the oxygen that you're using for the patient. If you calculate that ratio, and if you take the pressure of oxygen in millimeters of mercury, it should be less than 300 millimeters, with a PEEP of 5 or less. And if that happens, and if you're able to exclude congestive cardiac failure or fluid overload in this patient, then you say that this patient has ARDS. Now, a lot of studies were trying to, in around 2000 or 10, around that time, they said that let's investigate the use of neuromuscular blockade in ARDS patient. And there was a certain reason why they wanted to do it. So the first reason they proposed in theory was when you are breathing normally, you're using your muscles for respiration, and that is not using more than 1 or 2% of your cardiac output and oxygenation. But let's say there's a patient who starts breathing using all the accessory muscles for respiration. Now this patient would start using oxygen more, and the cardiac output would increase in this patient. As a result, if you look at alveoli and the vessel interface, there will be a lot of thinning of the endothelium that will happen, and the fluid will start leaving the vessel space and start entering into the alveoli, and that leads to edema. So if you use neuromuscular blockade, that can stop this from happening, excessive use of the respiratory muscles. That was one thing. The other thing was, we often see, even today, there are a lot of patients who go into dysynchrony if they are on ventilator. That is, patient is making their own breaths while the ventilator is in some other phase and it's trying not to give the breaths up. So there's a dysynchrony that happens, and that leads to what is known as barotrauma, trauma because of excessive pressure, or leads to volutrauma, trauma due to excessive air being entered into our alveoli, excessive volume. That can happen, and obviously this dysynchrony, if you use the neuromuscular blockade, then this dysynchrony will be gone or will be minimized. The other thing that happens with patients who are trying to breathe excessively on their own is either they take too high a volume. So what happens is they again get either barotrauma or volutrauma, or they might breathe, so they might breathe everything out, and then what happens is there's no pressure to keep their alveoli open, and as a result, the alveoli, they collapse. And that is called as atelectrauma, which you can see here. So again, if you use neuromuscular blockade, you can stop this from happening. So all of this, barotrauma, volutrauma, and atelectrauma, are combined together, known as ventilator-induced lung injury. So around 2010, a lot of trials were conducted in France, which showed, one study showed that if you use neuromuscular blockade, there is a decrease in what is known as interleukin-6, which is good. That means less of inflammation is happening in these patients. That could be a good thing. The other studies, they said, well, there is a reduction in mortality in some of the ARDS patients in whom they had used neuromuscular blockade. So one of the very popular studies was ACURASYS. This in 2010, they published the result. This was done in France. This was a multi-center trial done in about 340 patients with a moderate to severe ARDS, and they used a neuromuscular blocker called cisatracurium, and they found that if they gave 48-hour infusion of this drug, it reduced the mortality in this patient versus patients who were only given deep sedation. So for longest of time, we all got excited about this study and everybody thought, okay, fine, let's start using neuromuscular blockade in ARDS patients. But there were some problems with these studies, with this study. Some of the doctors, a lot of doctors in the US were very reluctant to use neuromuscular blockade. One of their reasoning was there is a weak recommendation by ARDS.net for the usage. And the reason why they said was because if you look at ACURASYS study, by authors' own admission, they said that their study was underpowered, number one. The other thing that was a little suspicious about this study was that the mortality that they reported was earlier the crude mortality, which did not show a significant difference. There was only a difference of 9%, which is not statistically significant. Then they tried to adjust few parameters, especially the P plateau, and then they said, they reapplied the statistics and they said, no, there is some significant mortality difference. But mind you, that was borderline. So since this was a borderline difference, which was pointed out by the studies, so the doctors were very reluctant to use neuromuscular blockade in ARDS patients. Other concern was when you give neuromuscular blockade to patient, you have to keep them deeply sedated. And why you keep them deeply sedated is because patients become more aware when you use neuromuscular blockade. So deep sedation had to be used, and deep sedation has its own problem. If you're using deep sedation, patients would have hypotension, can have bradycardia as a result of side effects of some of the drugs. So you would have to go high on your fluids, or you will have to go high on your vasopressors. So all these complications the doctors did not want. So they were very reluctant about using neuromuscular blockade in ARDS patients. So most of the doctors would use neuromuscular blockade based on the results of ACURASYS studies if their patients were showing ventilator dysynchrony, if they were not able to control it by any other methods. So till about the time when ROSE trial was conducted, there was a lack of study that showed usage of neuromuscular blockade with deep sedation versus the control, which would use light sedation, because light sedation is what we have been using in current days. So there was no study which was conducted before ROSE trial like that. So there was a group called Petal Group. They designed this study as a part of phase 3 trial. It is a multi-center studies. It was done in US across many centers. It was unblinded, and it was actually not totally unblinded. It was blinded to the fact that while the patient was in the hospital, the researchers who were observing the patients, they knew that these patients are on neuromuscular blockade and those who are not on neuromuscular blockade. Apart from that, they were blinded when they later saw the patients when they were out of the hospital. The similarities, so the design was to keep it as similar as possible to the first trial, that is ACURASYS. So the similarity was that both in ROSE trial and ACURASYS trial, they have used the same agent, that is cisatracurium. In both the trials, they tried using conservative fluid strategy. And the only time they gave excess fluid boluses was in patients who were in shock, who could not be managed otherwise without the fluid boluses. But there were some significant differences from the ACURASYS trial. The sample size has been different. So ACURASYS has studied only 340 patients, whereas ROSE trials have studied more than 1,000 patients. ACURASYS, as I said earlier, they tried to adjust their statistics by reporting their mortality. Also in ROSE trial, they have used high PEEP as compared to low PEEP strategy that was being used earlier at that time. And also in sedation, in control group, ACURASYS gave deep sedation to their control group patients, whereas ROSE trial had given light sedation following the strategy that is being used these days for ARDS patients. So those are the differences. So what patients did they include in their study? Patients who were mechanically ventilated for less than 5 days were randomized into this trial, who had following criteria, who met following criteria for less than 48 hours. So as soon as they met this criteria, they would be randomized into the trial, and they would take less than 48 hours to do it. So that was what they were aiming to do. So these patients had PF ratio of less than 150 millimeters of mercury and a PEEP, and they required PEEP greater than 8 centimeters. Also, these patients met the Berlin criteria of having bilateral pulmonary opacities widespread on their chest X-rays or CT, and patients had cardiac failure and fluid overload ruled out. They had a lot of exclusion criteria, and they had some reasons behind it. So if they would not include the patient who would refuse to give the consent, if the patient had neuromuscular blockade trial prior to entering into the study, they would exclude that patient. Pregnant patients, because cis-atracurium had not been tried on pregnant patients, so this is why they excluded pregnant patients. Also, they excluded patients on ECMO at the time of assessment, patients who had chronic respiratory failure, patients who were on home ventilations, high BMI patients, patients who had chronic liver disease, patients who were going to receive bone transplant, patients who would be placed on end-of-life strategy, patients who were not expected to survive beyond 24 hours, diffuse alveolar hemorrhage, again, because pathophysiology of alveolar hemorrhage is different from ARDS. They decided not to include severe burns patients, because in those patients you can't follow a restrictive fluid strategy. They also decided not to include patients who would have hypersensitivity to cis-atracurium, or patients who had some neurological conditions like Guillain-Barré syndrome or other channelopathies. They also decided not to include patients who had a PF ratio of greater than 200 after meeting the inclusion criteria, but before randomization. And also they excluded patients on lung transplant list. So, yes, please.
Consent.
So the consent was, informed consent was given by the patient's bystander, just like how we obtain. So by the patient's relatives, by the caretakers of the patient, those who were legally responsible for that. So they obtained an informed consent, and with all the information.
It's not a consent if you're taking from a relative.
That's how we've been consenting for
they have been
studies.
Okay.
Yeah, that's the consenting protocol. Yeah. Because mostly patients going to be intubated and
okay, so
this is the best slide of the whole thing.
Yeah, that's me and that's me, in case you're wondering. So As soon as they matched the criteria, they were randomized within 42 hours of developing ARDS. So they were divided into two groups, the intervention group and the control group. In the intervention group, they decided to give neuromuscular blockade, that is cis-atracurium, with deep sedation. So they followed the ACURASYS trial while they gave cis-atracurium to this patient. They decided to give a 15 milligrams of cis-atracurium bolus, followed by an infusion of 37.5 milligrams per hour. This, mind you, is a very high dose for most of the patients. And why 48 hours, you might wonder, and why not more? Is because after 48 hours, most of the studies indicated that you start getting the bad effects of neuromuscular blockade, like ICU neuromyopathies. So which is why they tried to stick to 48 hours and not beyond that. They said that they would stop neuromuscular blockade early if the patients, let's say, they met the criteria for freedom from mechanical ventilation for, let's say, 12 hours. That is, that they required a FiO2 of less than 40%, and they required PEEP of less than 8 for more than 12 hours. Then the cis-atracurium could be stopped on these patients earlier than 48 hours. Or if there was an independent group of people who were observing these patients for bad reactions to the drugs. So if they found that the patient was too bradycardic on cis-atracurium, or if the patient developed allergy or any other adverse reaction to cis-atracurium, they would stop neuromuscular blockade on that patient, but they will still include these patients in their study. They decided that they would aim for a RAS score of -4 to -5 in these patients to maintain deep sedation on this patient. Coming to control group, they decided not to give any neuromuscular blockade to control group and keep them lightly sedated, and by achieving a RAS score of 0 to -1. And it was left to the discretion of the treating consultant which sedation they wanted to use and how they wanted to use it. They did not interfere with that. So there were certain things that were being or could be done commonly to both the groups. They decided to use the strategy of low tidal volume and high PEEP up to 5 days after randomization in both the groups. They decided that they could lower the PEEP if the patient had hypotension, and even after giving fluid boluses and vasopressors, they could not treat the hypotension. Or if the patient had high plateau pressures of greater than 30, which you could not, which stayed high after using your recruitment maneuvers and other maneuvers. Or if the patient was highly acidemic, less than 7.15 of pH, or if there was a chance that patient could have pneumothorax, if the patient had bullae, then they decided they will not use high PEEP, they lower the PEEP. So coming to proning, both patients on both the groups could be proned, and this was again left for the clinicians to decide whether they wanted to prone the patient or not. But they did recommend that clinicians should try avoiding the proning the patient at least for 12 hours after ARDS, and if possible, to avoid using the neuromuscular blockade use on these patients. Still, in both the groups, you could use rescue neuromuscular blockade in the form of 20 milligrams of cis-atracurium if the patients met a pre-specified criteria. So if they had plateau pressures of greater than 32, they could use first dose of 20 milligrams of cis-atracurium. Then it was decided to observe the patients. If the patients did not have a reduction in plateau pressures by at least 2, they could give 1 more dose of cis-atracurium in both the groups. So in effect, the patient could receive 2 boluses of cis-atracurium. So after 48 hours, it was left for the clinician to decide whether they wanted to continue using cis-atracurium or not, or if they wanted to switch over to some other agent to keep the patient relaxed. In both the groups, certain rescue measures were allowed. They were allowed to do the recruitment maneuver. They were allowed to use inhaled nitric oxide and epoprostenol, or use high frequency ventilation, or use ECMO when needed. They also decided to wean the patient so they were using what is known as FiO2 and PEEP. So they were titrating PEEP, keeping FiO2 in mind. And this is according to ARDS.net strategy. So if you look at that table, it says that if you're below 40% of FiO2 with a PEEP of less than 5 or less than 8, then you can think about stopping the neuromuscular blockade. So they would evaluate the patient after 12 hours. And if the patient was meeting that criteria, they would then evaluate the patient for safe extubation. And if the patient met the criteria, they would stop the neuromuscular blockade and extubate the patient even before meeting that 48 hours period. So so initially it was decided to use 1408 number of patients, and how they reached at this figure was they assumed, based on previous studies, that at least 27% of patients in intervention group and 35% of patients in control group would die. So after doing the power analysis, they reached at the figure of 1408. So whether the strategy of using neuromuscular blockade for almost 10 years after ACURASYS came up with the results, whether it was a good idea or a bad idea, we'll know soon after Mia discusses the results with you.
All right. Does anyone have any questions so far? So the question is, if someone's in ARDS, moderate ARDS, does paralyzing them improve their mortality? That is basically the question. And so, as Sebi said, it was a much bigger study than ACURASYS, over 4 years, with just under 5,000 patients screened at 48 different centers in the US. They included 1,000 patients in the primary analysis. A very high number of patients were excluded after screening because clinical improvement. And then also quite a large number were excluded after screening because they'd been given neuromuscular blockers, which was one of the exclusion criteria. So they ended up with intervention and control groups that were about 500 each. So the primary outcome measure was in-hospital death from any cause at 90 days. So basically, was the patient still alive at 90 days? And then secondary outcomes of serious cardiovascular effects, and then a long range of secondary outcomes, which we don't need to go into. So basically, in terms of primary outcomes, 42.5% of the intervention group and 42.8% of the control group were dead at 90 days. So a difference of 0.3% with a p-value of 0.9. So that is significant, not significant? Guys, not significant. So there's no difference between the two groups.
Yes.
Hello.
So basically, there was no difference in between the two groups.
Oh, Rose.
The intervention and the control group. Guys, the presentation's being recorded, sorry, so it's just very hard to hear. There was a difference in terms of serious cardiovascular effects, so 14 in the intervention group versus 4 in the control group. But you might remember Sebi talked about sedation, and the authors in the write-up felt that the number of cardiovascular effects in the intervention group could be due to higher sedation than in the control group. And then in terms of the other secondary outcomes, there was no difference. So ITU-acquired weakness, need to have ECMO, 28-day mortality, long-term assessment of quality of life and awareness. So in conclusion, there was no difference. So there was no survival benefit for giving neuromuscular blockers, which was not what was found in ACURASYS, which seemed to suggest that there might be. In terms of comparing the two studies, there's 3 main differences: PEEP, proning, and sedation. So in Rose's trial, there was a slightly higher PEEP strategy, and we know that higher PEEP is potentially helpful in ARDS. So that might have reduced the mortality in the intervention group, in the control group, which may have sort of cancelled out any difference in mortality. In terms of proning, there were much fewer patients who were proned in the ROSE trial, 16% versus 50%, so that the authors hypothesized may also have diluted the effects, and sedation, as we mentioned. So in ROSE, there was much lighter sedation in the control group, with aiming for a RASS of -1, which is more in keeping with our kind of current ITU practice. So Subby's already talked about ACURASYS. So it's the other kind of major study asking the same question. It was much smaller, only 340 patients in 20 ITUs in France. And they found that their primary outcome, which was 90-day mortality, there was a difference in the adjusted analysis. So on the raw, and we'll talk about that briefly in a minute. So there was a difference of 9%, which wasn't significant until they adjusted it for baseline variation in PF ratio, SAPS-2, which is a sort of scoring system for physiological disturbance, and plateau pressures. So just an easier question, why do we randomise in studies? What's the point there?
To reduce bias.
Yeah, yes, exactly. So, oh, we got upgraded. So yeah, so randomisation controls for non-random error. So things which might come up through a non-stochastic process or bias. So the idea of randomising is that random confounders will be equally distributed between the two groups, so that the intervention will be the only difference between the active and the control groups. Randomisation doesn't control for random error, if that makes sense, or issues with random sampling. So what do we do in study design to try and reduce the effect of random error? How can we do that?
So through the power calculation.
Yeah, and what is one of the important aspects of the power calculation? Very basic in terms, so if you were going to do a survey of ITU doctors for their opinions about training. Yeah, exactly, yes. Sample size. So you can reduce your probability of having random error by increasing the sample size. So in an unadjusted study, you can quantify the risk of random error, and we do that using the confidence interval, but we don't try and control it. Whereas in the analysis of ACURASYS, they'd done a secondary loaded statistical analysis to try and quantify and remove random error, which basically left the study quite significantly underpowered.
Did they apply correction to that?
Yeah, so they corrected for differences in PF ratio, the SAP score, and plateau pressures. So it's basically as a sort of overcorrected in a study which was already quite small. Mm-hmm. So in terms of the critical analysis of the ROSE trial, the strengths are that it was randomised, it was an intention to treat analysis. Does anyone know what that means?
Everyone that was included.
Exactly. So the way I remember it is once randomised, always analysed. So rather than looking retrospectively at who got what treatment, you start at the beginning and include everyone who was randomised, regardless of whether they were subsequently excluded or. So you end up with, you use all of your sample size. There was good compliance with the protocol, so across the both group, across the intervention and control group, there was very kind of accurate adherence to the study protocols in terms of PEEP and sedation. There was a large cohort, as we've said, and they used high PEEP and lower sedation, so basically a management strategy which is more in keeping with what we traditionally do in ITU at the moment. In terms of weaknesses, it was unblinded, as Serbi said. A high proportion of patients were excluded. There was a bias in favour of the control group because so many patients were removed because they'd already had neuromuscular blockade. They didn't monitor neuromuscular blockade, so they measured the administration rather than the efficacy. Does everyone kind of understand what I mean by that? So we are giving someone an agent which paralyzes them, but they were only measuring whether they actually got the drug rather than whether they were actually paralyzed. So normally in ITU we would use trainer 4 monitoring or anesthetics, so test muscle twitch in response to electrical stimulation, and that way you know if they're actually paralyzed, whereas we weren't monitoring whether they were actually paralyzed, they were just monitoring whether they were given the drug. And lower rates of proning potentially was a confounding variable. So in terms of what does this mean? So the conclusions of the ACURASYS trial was that liberal use of neuromuscular blocking agents would likely confer survival benefit in patients with moderate ARDS. I would say the conclusions that we can draw from the ROSE trial is that you need to exercise caution in your sort of statistical analysis, because if you read the conclusion of the ACURASYS trial, you could sort of see that there was a statistical difference, but it wasn't sort of, everyone forgets the sort of postscript, which is the secondary correction, and which left the study quite underpowered. And in terms of what should we do in terms of our clinical practice, I think basically we know that neuromuscular blockade may be helpful in selected patients with ventilator asynchrony, but not as a sort of broad brush treatment for any patient with ARDS. And these are the references. So we highly recommend Life in the Fast Lane. I'm sure what's Johnny's website, Life in the Fast Lane. The bottom line is a great site which digests lots of these kind of papers, and EM crits is similar to the bottom line. Does anyone have any questions?
Alex has questions.
Thanks, Alex. Are you still there?
I'm still here. Thank you very much. Is anyone asking any questions?
No. Oh yeah, you can't see everyone, sorry.
Oh, that's all right. Okay. Thank you very much.
All right, thanks.
Thank you, Alex.
Thank you. Do you know if the others want to do their presentation as well?
Flavia's not here today.
Fair enough. Okay, we will postpone that. Thank you very much, Mia and Serbi.
Bye.